Hi everybody, so now we're going to talk about the elderly population as well as palliative care. This is chapters 47 and 52 in the 5th edition of Darby and Walsh, and it's chapters 55 and 61 in the 4th edition. There's a lot of objectives here. This is pretty heavy content, and it is very difficult to really get all the content for this population in one class. It's sort of probably summarized quite a bit in a lot of places and skimmed over because there's a lot of factors that affect individuals as they age. So we're kind of zeroing in on the most pertinent, and then I always encourage you to do more research on your own and take other continuing education courses about all the very aspects of caring for the elderly in all different stages of life, from the young old to the old to those in palliative care or hospice or something like that. There's a lot of area for growth in this part of our industry as well, and for those who are interested in working in direct access as well. So Healthy People 2020, improve the health, function, and quality of life of older adults. Our statistics, of course, we've talked about this for a long time. They call it the silver tsunami. All the baby boomers are aging now, and so the population of the geriatric population, or the older adult, is going to keep growing for a number of years until we get to about 2060. The population percentage will be right around 23% of the U.S. population. The demographics of aging population. Aging adults experience higher risk of chronic diseases. So that's the difficult part, is there's kind of a burden of care. There's many chronic conditions that can kind of come in together, and so somebody is not just treating one, but there's many comorbidities and factors that need constant medication and care, and so people are living longer, and oftentimes they're living longer with chronic disease. In 2012, 60% of older adults managed 2 or more chronic conditions. And those chronic conditions are, of course, heart disease and cancer are big ones, chronic bronchitis or emphysema, some kind of a lung disease, having a stroke and residuals effect after stroke. Diabetes is, of course, a really big one as well. That should probably go up closer to the top. Alzheimer's and dementia, neurological conditions, that creates a whole host of issues with needing constant caregivers. Arthritis and vision and hearing problems are also very common conditions. So when we talk about caregivers, we're talking about people who assist this population. They assist with activities of daily living, or helping them get dressed and get food and go about to run errands. They may have to bathe them, help them use the toilet. Approximately 25% of U.S. adults 18 and older provide care to a person with long-term illness or disability in the past 30 days. So that's obviously a snapshot from one statistic, but there's a very large group of people that need caregivers. It's a large group of the population. Increased risk for negative health consequences, including stress and depression. When you're dependent on somebody else and their kindness and their level of ability to care for you, there's a lot of a loss of autonomy and feeling of control of your own life, and that can lead to distresses, mental distresses, a feeling of isolation and loneliness and depression. So a lot of that stuff goes together. Additional support to persevere through their own health. A lot of people who need a caregiver still want to be able to do some things on their own and as much as they can without relying on somebody else. It does bring a lot of positive mental feelings. Greatest risk of caregivers of Alzheimer's, of course. It's very challenging to care for somebody with Alzheimer's or severe dementia, and that's just a topic all on its own. Oops, let's see. how do I advance here? Healthcare for older adults. So we want to know the different terminology. Geriatrics is a branch of medicine. It's concerned with the illness of old age and their treatment. So geriatrics talks about medicine, a branch of medicine. Gerontology is the scientific study of factors affecting the normal aging process and effects of aging. So the terms are not interchangeable. So if it's a geriatric practitioner, it's a doctor of geriatric medicine. If they're studying gerontology, they're studying the factors that affect aging. Determining health status, characterization of age. So we want to think about chronological age versus functional age. This can be, you can have a very high functioning 99-year-old, or you can have a very dependent and low functioning individual who's 57. So we kind of think about these in those two terms, chronological age versus functional age. Activities of daily living is a term you see a lot in studies and journal articles that they study this, the individual's quality of life and their activities of daily living and how that affects their mental health and what they can accomplish. So that's a term you see quite often with special needs and with geriatric individuals. Instrumental activities of daily living. So they break it up into things like being able to do the main functions like things like feeding yourself and using the toilet and showering. And then there's things like getting around, making appointments, and being able to interact with people on a more social level, things like that. Acute conditions, more prevalent in the early 1900s. Chronic conditions are more prevalent today. So an acute condition was something that came on strong and did you in. And that was before we figured out how to maintain and treat conditions. And now they're chronic conditions. So people, might live longer, but live longer in a sick state or in a state that requires a lot of medications and care. Common cognitive disorders, dementia and Alzheimer's. So progressive intellectual decline leading to a deterioration of occupational, social, or interpersonal situations, rising in frequency with age, and they result from a death of the nerve cells. So in early stages, you'll see a diminished energy, a diminished enthusiasm for things, diminished emotional instability. There'll be more mood swings, awareness of failing mental function. Early stages, people with dementia oftentimes know something isn't right, something's changing, and it's frustrating. Disease progression, impaired cognition, leads to increased disorientation. It affects the language, affects perceptions of things, ability to learn a new skill, and affects judgment. Increasingly, they're more self-absorbed, anxiety increases, mood swings increase, and then if their judgment is very poor. Continued progression, we see more of a flattening of the mood. There's the mood swings leave, and then there's just a flatness of the mood. Personal cleanliness deteriorates. There's no more of a feeling of importance of bathing and taking care of oneself and cleanliness. Other neurological issues such as seizures, inability to communicate, and then a total dependence on somebody for their care. In Alzheimer's disease, it's a form of dementia. In 65 years and older, Alzheimer's is present 10%. 85 years and older, Alzheimer's is present in 50% of dementias of 85-year-olds and older. The brain disorder that gradually destroys the ability to remember, reason, learn, and imagine. It's progressive destruction of the neurons. Oh, crap. Let me see. Oh, did I just say crap on here? I'm so sorry. Trying to get rid of this. Oh, my word. I was trying to see that last word. Progressive destruction of neurons and atrophy of the cerebral cortex is what's happening with Alzheimer's. Let me get back to a presentation view. Here we go. Okay, so early stage, simple forgetfulness, personality changes, and then as it progressed, daily living tasks are lost, the inability to just perform those simple tasks, difficulty with communication, both written and spoken, and then in the end stage, they're completely bedridden, unable to recognize themselves or their families, and then they don't even know how to eat. And at some point, like all the functions, the neurons and the cerebral cortex becomes completely destroyed, and that's what ultimately leads to the death. So oral care with cognitive disorders. So when if we're taking care of somebody with a dementia or Alzheimer's, things that are important to know about is the neglect leading to caries and periodontal disease. Clearly, if somebody is losing their cognitive faculties, they're going to neglect their oral care, and they're going to be dependent on somebody else to do that for them. So they're going to forget to brush their teeth, forget how to brush. They may not want to brush. It may be like, don't, get that thing out of my face, may resist the caregiver caring for their teeth. And this is a frustration for caregivers in long-term care facilities, is that they don't particularly want to clean somebody's really dirty mouth that smells atrocious, but then when they do try, the patient with dementia or Alzheimer's fights them, and then they're like, oh, forget it. So it's a vicious cycle, really. Gingival hyperplasia related to anti-seizure medication, early morning appointments, and stress reduction and less fatiguing is a good rule of thumb. We'll see that repeated over and over. Our early morning appointments, short early appointments when the patient's not so exhausted. Schedule when office is not busy and less noisy, so there's less distractions and they feel more at ease. Easily confused with changes, so it's nice if they know the same person or if a family member comes with them. Approach caring and understanding, approaching them with a calm, sort of empathetic, understanding, non-accusatory. You never want to contradict them if they tell you something. You never want to say, no, that's not right. If they say something like, you stole my toothbrush, oh, I did. Well, let me get you another one. Something like that. You never want to tell them that they're wrong or that they misunderstand something, because it really just leads to more frustration and more heightened anxiety. Limit their choices with the tell, show, do, and want to keep it very simple. The most simple and effective tool to remove the most bacteria. Speak slowly, clearly, in short sentences. Oral hygiene instructions determine self-sufficiency and the ability to use mouthwash. So kind of determine what they're capable of and then integrate the process with a caregiver. Oral changes in the aged population, so that we see dental, periodontal, oral mucosal, tongue, salivary gland, drug-induced changes, and other changes, but really almost all of this is due to systemic health, systemic diseases. It's not as often that you see it, but if you were to see somebody as they age who is able to maintain their health, minimize systemic diseases, there actually is very little oral changes that happen. So a lot of these is a direct relation to disease of some kind, medication, systemic disease, chronic disease. Dental changes, age-related. So there's been an overall decline in edentulous, 65 to 74-year-old. In the 1960s, it was like 50% of everybody lost their teeth. It was just like part of aging. Like you get old, you lose your teeth. But that has minimized considerably. It went from 50% in the 60s to half that in the early 2000s. And now that we're 2020, I'm not actually sure. I don't have the updated number. I wonder if the textbook has it, if I can find it really fast. But, oh, dang it. I'm going to pause it. Hold on. Okay, I found it here. So in the book, it says the last number they have is in 2012, edentulism, or people with that were edentulous, was down to 18%. So you can see it keeps going down because, like everything, we are treating all kinds of diseases better than we ever have before. So one of the biggest places, though, that you will definitely see changes in somebody's mouth, and it's not necessarily actually, this is really truly actually more age related, are the actual teeth. So like with everything, we age, our skin gets more wrinkly, our hair turns gray, our hair becomes thinner, we do tend to lose muscle mass. So we age, our teeth age. Our teeth have been in the mouth, you get your full permanent set somewhere around, 12, 13 usually. All your permanent teeth come in, and then that's it. That's all you got, right? So you use them every single day. There's not a day go by that you don't use your teeth. So we see things like we see fractures in the enamel. We see staining. It uptakes stain from a lifetime of eating and drinking things. Slower production of dentin. The dentin cells don't turn over as much. So we see a change in the dentin, the cementum, the periodontal ligament space, the pulp, shrinkage of the pulp in general. Elderly people tend to have less tooth sensitivity. They're not as sensitive to cold. They're not as sensitive to, like the metal scraping on their tooth. In general, I have definitely had older individuals who say that's sensitive on my tooth. But in general, we do see a shrinkage of the pulp and less sensitivity. See here if I have any other notes on that. Tooth wear, attrition, erosion, and attrition is also common. A lifetime of just habits, just grinding, dietary factors, high acid diet, maybe someone liked lemons, and things got eroded. So we see these things. If someone grinds their teeth their whole lives and they don't wear a mouth guard, we're going to see a ton of grinding. Or if they clench a lot, if they clench during the day out of some kind of a nervous habit or something, or if they went through a bout of eating disorder or had, vomited for some other reason, so we will see these these parafunctional habits and these habits from dietary choices and life circumstances as people age. Pathology related. So of course, again, we can see the scarring or the residual effects of caries. Root caries is the most prevalent that starts happening in aging, and that is usually directly related to a systemic condition or to medication. So you're not going to have root caries unless you have recession, right? And a lot of times we'll see the residual effects of someone who might have been dealing with active periodontal disease. Maybe the periodontal disease is stabilized, but the root exposure is still there, and the roots are more susceptible to decay. And if they have a dry mouth for systemic reasons or medication reasons, then they're more prone to root caries. So contributing factors: recession, salivary quality and quantity, composition and quantity, inability to complete thorough oral hygiene, previous restored coronal or root decay, they get recurrent decay around those areas, overconsumption of fermentable carbohydrates or soft foods, and frequent snacking. So all the same risk factors for a kid that's high risk for caries, but just usually a different part of the tooth in the older population. Periodontal changes. So again, a lot of times if somebody is systemically healthy, that doesn't mean their bone is just going to whittle away and their periodontal ligament space is going to widen and they're going to destroy bone just because they're aging. There are things that happen with osteoporosis and metabolic systemic things that have a greater effect. So absence of disease, there's really not a big change. Quality of bone reduced related to metabolism and reduced healing capacities, of course, reduction in gingival nerve and gingival vessels, blood vessels. So there's the normal aging component, but what really accelerates it and causes a significant change is a disease process. Pathology related, so association, not cause, between increased age and increased recession, loss of attachment, prevalence of inflammation, perio health in middle age, predictor of later in life. So if somebody has, a high susceptibility to periodontal disease, and then on top of that, they don't do very much to get it under control, then that's going to be quite a predictor of what happens later in life. Age-related mucosal changes. So absence of disease, no massive changes. Pathology-related medication or systemic condition, again, lips appear dry, drawn, loss of elasticity, dehydration. Angular cheilitis is often seen as you get that kind of loss of elasticity in the folds in the corners of the mouth. Ill-fitting denture, oral cancer above average Average age of diagnosis is 60 years and older, and most common in men over women. Of course, now we're seeing oral cancers too in the younger groups as well, but we'll talk about that later. Tongue changes, decreased in the number and sensitivity of the papilla, decrease in sense of smell. So obviously our tongue, our taste and our smell they work together. They work sort of in tandem or together. Food's less of an appeal. Nutritional needs may not be met. So they might want sweeter foods, saltier foods, things that because they can't taste and smell as well. So then they're going to go for something that is, sweet or has more flavor. Sublingual varicosities, those big, deep, reddish blue, black dilated vessels, often seen under the tongue, but you may see it in the buccal mucosa or the inside of the lip or something. Either side of the midline and the ventral surface of the tongue. Nutritional deficiencies, we'll see anemia. With anemia, there's atrophic glossitis. And often burning mouth sensation. It can often be seen with nutritional deficiencies. A smooth, shiny, and denuded tongue can be a predictor or an oral manifestation of nutritional deficiencies. And then in the edentulous, the tongue size can increase. If there's no teeth, your tongue kind of spreads out to fill the space, so the tongue can become larger. Salivary gland changes, not related to age. Again, this usually has more to do with systemic conditions or disease related to radiation therapy, tumors, or medication. If present with no medications, evaluate for underlying disease or salivary tumors. So that might be if they're not taking a medication that causes xerostomia, then you want to think of other things, like could something be going on? Sjögren's syndrome, most frequently in postmenopausal women, 60% older than 50% or 50 years old. Oral mucosa extremely dry. Saliva is ropey. First, you'll see the atrophy of the papilla, and then later there'll be that smooth and lobulated tongue, like looks like nodules or lobules on the surface of the tongue. Salivary gland changes. So we want to think about the purpose and the importance of saliva, and then what it means to have diminished saliva. So the purpose of saliva is to lubricate the oral mucosa, obviously. Keeps everything, it kind of helps combat that. You'll get that excess inflammation on top of just the bacterial caused inflammation if we have dry oral mucosa. It assists with processing food in our mouth, starts to help break it down, and then lubricates it so we can swallow it. It assists in speech, so our tongue doesn't get stuck on the roof of our mouth, so we can actually formulate our words a little easier. Dry mouth hinders that. Facilitates retention of oral appliances. If we're dry, the denture doesn't, our partials don't fit as well. Provides a source of minerals for remineralization of enamel, so we're constantly remineralizing those areas that get acid attacks, and it neutralizes the pH of our mouth. If we don't have saliva, we see an altered taste, contributes to the plaque formation and retention, contributes to dental caries. Mucosa can appear dry and inflamed. Edentulous persons, it affects the denture retention, the comfort of the denture, their ability to chew and speak. So those are kind of doubling up on what we just said. So drug-induced changes, a third of prescriptions are for older adults. On average, they take more than 3. Institutionalized can average 5 to 7. I've seen statistics that say more than that, 10 plus. Most commonly used by older adults are analgesics or pain medications, diuretics, high blood pressure, oral hypoglycemic, diabetes, antihypertensive drugs, high blood pressure, antidepressants. That's a big one, especially as they move into long-term care facilities, and sedatives. That's a big one also for sleep disturbances, and then also dementias and Alzheimer's. Drug-induced changes, we can see gingival enlargement, anticonvulsant medications such as phenytoid or Dilantin, cardiovascular drugs, calcium channel blockers can cause gingival enlargement. Immunosuppressants can cause gingival enlargement. Xerostomia is a huge one. Antihypertensives, antipsychotics, antidepressants, muscle relaxants, antihistamines, laxatives, and diuretics all will cause xerostomia. Other changes, an increase in halitosis or bad breath. This could be from upper respiratory conditions. This could be from excessive mucus or an infection in the upper respiratory system. Packing food, pouching is what they call it. In the long-term care facilities, patients pack food. They don't know how to clear anymore. They might have a drier mouth, and they lose sensitivity in knowing how to move their tongue around their mouth to clear out food that's in the vestibules and swallow it down. So it starts packing in the cheeks and in the vestibules. Food between cheeks, lips, and soft tissue, inability to swallow, loss of sensation, muscle weakness. So all of that is what contributes to that packing of food. Okay, let's just pause here and then we'll pick up with assessments.